that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. Here at P4HE, we convene these sectors to work together to better understand critical issues related to attaining health equity. One of the ways we do this is by providing spaces for activities to engage with these groups in insightful conversations on timely topics and to promote actionable solutions. Today, we have a panel of practitioners with expertise in health equity for people with intellectual and developmental disabilities. Individuals with intellectual and developmental disabilities, or IDD, face various structural barriers at all ages, spanning from activities of daily living to education to employment and independent living. Additionally, studies have shown large racial and ethnic, as well as gender disparities in health and healthcare that stem from barriers to accessing quality care and bias against people with disabilities. I apologize. One of the things that we want to focus on here is that we want to lift up the importance of making sure that people with IDD are not just a part of this work, but are driving this work and making decisions. The needs of people with IDD must be addressed to ensure equitable provision of services and supports while simultaneously working to break down stigmas, disrespects, and unjust systems and institutions that negatively affect people with IDD. Just want to point out that we have a podcast episode coming out at the end of this month on work for people with IDD and work that is done for people with IDD. So this podcast is on a study where people with IDD are a main part of the study team. So we actually encourage you to keep an eye out for those podcast episodes that will be dropping at the end of the month. But today, we have speakers who will share their insights on the unmet health needs of people with IDD. They will talk about the drivers of health inequities among people with IDD and how to work toward health equity for people with IDD. Speakers will discuss ways that we as a community who is dedicated to health equity, so that's policymakers, health equity researchers, healthcare providers, communities, advocates, and academics can collaborate to center individuals with IDD when designing and implementing equitable health interventions. So, like we always do, we want to start off with hearing from you. You all, of course, have valuable opinions and insights on health equity in general, and we want those to drive today's conversation. So we'll be using Mentimeter like we always do. You can access by scanning the code on your screen or by going to www.menti.com on your cell phone or your internet browser and typing in the number 56296653. So I'm going to do that as well. And so all you do is go to menti.com and type in that number, and a screen will pop up where you can give us a thumbs up to say that, hey, I'm in Menti, I'm ready to participate in this poll. And really, this is just a way for us to get the conversation started. The panel will also respond to what we say here. So I think we can go to the next slide. Okay, yes. So on your screen, it asks, how familiar are you with intellectual and developmental disabilities? So this one is pretty straightforward. You can pick your choice or you actually rank them. And I'm going to do the same. All right. Okay, so of course, when you're doing a live poll, you see the numbers changing on your screen, but most of us are somewhat familiar, followed by a little familiar, extremely familiar. And we assume that this topic is of interest, particular interest to a good deal of our audience. So we assume that, and then some people are not familiar at all, and that is totally okay. We're gonna have sort of a wide-ranging conversation here. So everybody should be able to fully engage. Yeah, thanks so much for answering that question. Awesome. Okay, the next question says, in your opinion, how do you think we all can work together to address equity for people with IDD? So in your opinion, how do you think we all can work together to address equity for people with IDD? So this one, you can type in your answer. You can spend some time to think about your response. You can also put in multiple responses. So what do you all think? How do you think we all can work together to address equity for people with IDD? I'm going to type in a response too. Okay. All right, so we have some responses. Okay, getting insights and engaging those with IDD in all sectors. Thank you for bringing that up. That is one of the core points of P4HE is having all sectors represented. So I think that this is important for this area because it can be relegated to the healthcare sector versus academia, but all sectors, including government, needs to be actively involved in equity. Thanks. Move out the way and give people power. Yes. Even though people already have power, it's people who take away people's power is the problem. Yes. More money, more broadly educating about the issue. Yes. Do a lot of listening and getting to know the experience of people involved better. Yes. Better training for healthcare providers. Definitely. Learning about barriers and enablers to care. Definitely. Reduce restrictions on the amount of savings. Yes, so some people may or may not know that things like the amount of money that someone can have in their bank account if they are receiving SSI is very much restricted. So yeah, thank you. We can address organizational policies that provide for more equitable care. Thank you. By actively listening and allowing those with disabilities to do the work. Yes. More research, more visibility, having a consistent understand levers that can be pulled by each stakeholder. Yeah, I really like that. So again, one of our goals here at P4HE is to not just talk about the problem, but figure out what we can do, those actionable steps. And one of those or approaches is understand the levers of power and who can make changes and how we can influence them. Work with people with IDD as well as caretakers, important to think about as caretakers as well. And others who care for or work with people with IDD, yep. Reduce stigma, yes. Annual training, yes. Supporting the individuals and their families with disabilities, yes. Expanding diagnostic criteria to incorporate lived experiences of marginalized groups so more people have access to resources. Thank you. I really appreciate that. Better reimbursement. Yeah, that's definitely an issue in the healthcare realm, but all sectors should be thinking about how to influence that. And firstly, by identifying them and making them know that we are here for them. Yes, thank you all so much. I really appreciate your engagement on that question. Like I said, it gets us to start thinking about this. It also helps our panelists be able to respond to our audience's needs. So thank you all so much for providing your input. As always, we are excited to have you here collaborating with us to take action for health equity. Please continue to share your thoughts and comments in the chat throughout today's webinar. You can ask questions to the panel through the chat or directly with the Q&A box. You can also join this conversation with your questions and comments beyond this webinar on Twitter by using the hashtag partners4HE. Okay, great. So thank you all. We're going to move to the panel. I'm going to introduce them and then just start asking questions. Like I said, if you all have any questions, feel free to ask. We'll start by introducing Darcy Milburn. Darcy is the Director of Social Security and Health Policy for the ARC. Hi, Darcy. There we go. Okay, hi. Great. Okay, next we have Beth Mallow, who is a professor in the departments of neurology and pediatrics and Burry Chair in cognitive childhood development at Vanderbilt University Medical Center. Hi, Beth. Hi. All right, and we have Maggie Nygren, who is the executive director and CEO of American Association of Intellectual and Developmental Disabilities. Hi, Maggie. Hi. And last but not least, unable to join us, but we wish that he was here, we have Greg Robinson, who is the Deputy Director of Deputy Director of Public Policy at Autistic Self-Advocacy Network. Unfortunately, Greg was unable to join us because he is under the weather, and we are wishing him well. So thank you three for being here. And if Greg were here, I would say welcome to him as well. But we're going to start off with asking Maggie. Again, I would have asked Greg specifically about autism spectrum disorders, but I'm going to ask Maggie if you could give us a sort of broad definition of what are intellectual and developmental disabilities, and maybe give us examples.
Sure. So intellectual and developmental disabilities are a group of conditions that are different conditions, but they all fall under a single umbrella in that they are conditions that are all apparent during the developmental period. That is apparent maybe prior to birth or up through adulthood, and they are lifelong conditions. They are conditions that people will, with supports, have better outcomes, but they are not conditions that can be technically cured. They are all conditions that exist on a continuum, so people will have strengths or weaknesses in different areas. Some people will have greater or lesser impacts based on their conditions, and they can have more than one condition. There are a lot of conditions that fall under that umbrella of intellectual and developmental disabilities, which we abbreviate by saying IDD, because it's very long to say intellectual and developmental disabilities. But the most commonly well-known ones are intellectual disability, which is the term that replaced the more old-fashioned term of mental retardation, autism, cerebral palsy, Down syndrome. Those are the ones that people really know. All of those can be had in various combinations or just one of those. And I would just like to stress that every person with a disability or without a disability has unique strengths and weaknesses. All of us have strengths and weaknesses. And so we would expect every person, a person with intellectual disability, to have great strengths in areas as well as weaknesses. And that if you've met one person with a disability, you've met one person with a disability.
Thanks for that explanation, and also for showing that there are conditions under this umbrella of IDD that are well known, that more people know about, as well as others that people are less familiar with. So thank you for giving that explanation and for pointing that out. I want to ask Darcy, I was also going to ask Greg this, but I'll ask Darcy, and if anybody else wants to jump in, if you could give us some examples of everyday challenges as well as health challenges experienced by people with IDD.
Great, sure. So I guess something to start out with is that from what we know from the research, and that's that individuals with IDD are disproportionately high users of healthcare service, but they report receiving poorer quality of care. They have poorer experiences at hospitals. They're less likely to receive preventive screenings and vaccinations, and they have poorer health outcomes, which, and unfortunately, along with all of that, shorter life expectancies as well. People with IDD experience higher rates of preventable conditions and poorly managed chronic conditions, including poor dental health, undiagnosed hearing and vision impairments, arthritis, obesity, diabetes, high blood pressure, cardiovascular disease, metabolic conditions, a number of various conditions that occur along with IDD. One thing that I'd like to just mention, though, is that when we start at barriers, people with IDD experience all the barriers that everyone else does, but to a higher degree in a lot of cases, and that can also be complicated by multiply marginalized identities. But challenges getting to the hospital, geographic challenges getting to specialists, challenges accessing health insurance itself, finding a provider that will accept them as a patient, and then it just goes on from there.
Thank you. Beth, did you want to also discuss this this question?
Yeah, I'd love to do it from the perspective of how do we move things forward, because sometimes Darcy did a wonderful overview, and it is, everything you said is so correct, Darcy. I think, though, I want to make sure people hear that there are things that are being done and changing. And one program I've been very active in that I'm so excited about is called Project Echo. You can Google it. It's basically expanding capacity for healthcare outcomes. And what we do is we bring clinicians, providers who want to get better at working with people with IDD, and they present cases de-identified. So we protect the identity of the individual being presented, but we present them to each other. We ask clarifying questions. We make recommendations. We do mini didactics. So that everybody can form a learning community. And the really cool part is we always have a self-advocate. So we'll have someone with the condition, for example, autism or Down syndrome, with us, so that they, just like we have psychiatry, neurology, and social work and everything else on the call, we also have self-advocates so they can share their lived experience with us of the challenges of healthcare. And together, it's much more impactful than just watching a CME in the background and cooking dinner or something while you're watching it. People actually have their cameras on like we do today. They interact, they discuss the case, and we grow together as a community. So I just wanted to add that there are things that are being done to try to improve care for individuals with IDD, including having the self-advocates part of the solution.
Thank you for that response. This is actually a question from the audience. That being said, I'm receiving some messages that the chat is disabled. So it's being fixed right now. I get a message that it's been fixed or it's being fixed. If you want to directly ask a question, you can use the Q&A function or put it in the chat if it's working now. But someone asked, are any of you all, okay, it's working now, great. So are any of our panelists parents of people with IDD or an immediate family member of someone with IDD? I have a follow-up question to that. And so, yeah, if you all could respond to that.
Yeah, I can jump in, and then Maggie. I have 2 sons on the autism spectrum. They're adults. So I feel like I've watched them grow through this. I'm a neurologist who specializes in sleep, and I actually changed my practice clinically and research because I saw such a need for people with autism to have improved sleep, autistic individuals. And it's been such a blessing for me to be part of this community. My kids are doing really well, they're adults, but it totally made an impact on my career for the better.
I'm also a parent of an adult son on the spectrum. And I'm obviously quite proud of him, as well as my other son who is not. on the spectrum. And, it's with all family members, you learn a lot. And it didn't affect my choice of career. I was already in the field. That's certainly a question that comes up. Well, is that how you got into the field? No, it's not. I was already in the field, but it did deepen my understanding of the field. So.
All right, thank you. Oh, sorry,
Oh,
Darcy. Go
and
ahead.
I can say, I'm not a direct family member of someone with IDD, but for folks that may not be familiar with the ARC is the nation's oldest and largest national organization that advocates for and with people with intellectual and developmental disabilities and their families. I speak with people with IDD and their family members on a daily basis. So very close relationships and friendships with people with IDD.
Thank you. I wanted to ask sort of an extension question, but it's really about something, Beth, how you began speaking about what we are doing. And, we have inequities, stigma, bias, unjust treatment of people with IDD in healthcare. My question was, how do you all as physicians and providers receive what people who have IDD might be telling you about their care? That was one of the things when we were doing the podcast that came up, that even well-intentioned providers and practitioners may have what they think are best practices, but the patients with IDD have other ideas and other solutions. How do you all manage addressing that?
Yeah, that's a great question. And I want to just acknowledge that it was so great having the audience share with us what they were thinking earlier. What a wonderful interactive exercise. I don't want to make it sound like the only challenge in caring for this population effectively is more training of providers. Absolutely, we need more training of providers, but there's so many other social determinants of health and inequities that need to be addressed besides the training of providers. And I think that you really hit on something important, Karen, which is we really need to hear from the people who are affected what they need. So we may not know that. So for example, someone on the autistic spectrum may be in a waiting room and it may be noisy to them. It may not be noisy to us, but it might be noisy to them. And can you imagine getting ready to have your blood drawn or get a physical exam, or if you're a woman having like a gynecological pelvic exam and you're already off kilter, right? You're already shook up from all the noise. So hearing about things like having headphones available for people who don't bring their own, figuring out how to set up the waiting room in such a way that's friendly, that's something that I might not think of, right? But our self-advocates will. So that's, I think, one simple example of helping. And what I'm going to do is I'll put in the chat something on, we have an IDD toolkit, which I think you already may have sent out to your, okay, all right. So as long as they got it, that's great. If you can't find it, it's Vanderbilt Kennedy Center IDD toolkit. You can just Google it. And it gives specific recommendations to help people with IDD. And a lot of those recommendations were driven by what we heard from self-advocates, which I really think is critical.
Could I jump in and just talk about some other social determinants of health? It starts from the very second that you think about wanting to go see a provider. All the steps that it takes to make an appointment, to communicate your need to make an appointment, to get to the appointment, or to schedule an appointment, to get to the appointment, to communicate your needs while you're at the appointment, to follow up after the appointment with your own care plan. All of these things are heavily influenced by where you live and what kind of insurance you have. If you have insurance at all, how much time the doctor can spare, if you can see a doctor, or if you're going to see another kind of allied health professional, how much time they can spare to see you, what kind of the training they have, what kind of staffing is available, what kind of physical space is available to you. I mean, all of these things contribute to the experience that you have and whether or not you're willing to repeat it again. You know, sometimes you say, it's not worth it to me. It was so unpleasant. I can't do it. And then people turn to emergency rooms as their first choice. And then that's not a good thing on our system. I mean, it becomes this, very, very challenging system for health that influences negatively people's health outcomes. So when we talk about our social determinants of health, it's not just as Beth was saying, it's not just training clinicians. It's all these systemic challenges that people face. So we have to address health access and health equity in a multi-pronged way.
Thank you for that response. I was literally going to ask about social determinants of health. So thank you for asking about that in the context of healthcare. I was going to also ask about it in terms of outside of healthcare. I was listening to an NPR story about marriage and people with IDD or disabilities and how that is restricted. And I know that marriage is not like one of the social determinants of health, in our academic sense, but it's a factor in people's real lives. So I was going to ask about how do you all think about how to advocate for equity in these social determinants of health that, it's not necessarily healthcare related. You could map out the ways that it is, but I'm wondering about advocacy for just a equal and equitable lived experience for people with IDD that may or may not be directly related to healthcare, but it's about, justice and people living their lives how they want to live. What do you all think about that?
Yeah, I'd be happy to speak to that because marriage equality is one of the issues that I work very, very closely on. And I would say that marriage equality is absolutely a social determinant of health, because if you think about it, marriage is about your relationship and your family being recognized by your community and your government. Right now, people with IDD who receive Social Security benefits do not have marriage equality. There's around 7.4 million people in the US that receive what's called supplemental security income, or SSI. If you're on SSI, if you get married to someone who's not on SSI, you risk losing your benefits altogether. If you marry somebody who's also on SSI, you risk a significant reduction, as much of a 25% reduction in the amount of income and the amount of assets that you're allowed to have. So it really does put people's lives and financial security on the line if they choose to marry and if they're recipients of SSI. There are efforts underway led by the disability community to advocate for marriage equality, and one of them is a bill called the Marriage Equality for Disabled Adults Act, which would eliminate marriage penalties for a certain subcategory of people that receive Social Security benefits. Another one is the SSI Savings Penalty Elimination Act, which would eliminate marriage penalties in the amount of assets that SSI recipients are able to have. I could create a whole nother event just about marriage penalties, but I do think that it's important to recognize that when I talk to my friends who are impacted by marriage penalties, it does have an impact on their health. They lose sleep about it. They have severe mental health impacts related to it. And it needs to be changed now.
Thank you. Any other social determinants of health that you all think we should be focusing on for people with IDD?
The list is long, but I will say that it's shared by people who are impoverished in general. You know, people with IDD are generally, in the United States at least, impoverished. So so people with IDD, as Darcy was saying, they're people who live in poverty. So they share a lot of the social determinants of health challenges that anyone in poverty will experience. And then they also share the marginalization, the social marginalization of having a disability. And then also gets amplified by any other social identities related to race or sex or any other identities related to sexuality or ethnicity or anything else that, again, contributes to perhaps reluctance to seek out healthcare, difficulties in accessing responsive healthcare and following through on responsive healthcare that can result in very, very negative outcomes. And I would toss this to Beth. I guess who could speak to that better than I can.
Yeah, I mean, as I'm sitting here, I'm thinking, what are the solutions? And working with our federally qualified health centers, our community centers, one program we're trying to do around sleep and autism, but I think it could be applicable to any condition, is we have some funding to train therapists in underserved areas, whether it be rural or inner city or whatever, or free clinics where families can go and get some help. I just think that's critical because you're so right that I mean, unfortunately, our medical center doesn't take Tennessee Medicaid. It's really frustrating because, you know, that's why we do all this work with these outreach programs that I mentioned, like the ECHO and the trying to get community health centers and community providers who provide care for free in many cases, trained in IDD, because we really do have this healthcare inequity in our country. So I think that's, you know, realizing that you don't necessarily have to be a doctor to be able to provide excellent care. A lot of our nurse practitioners, physician assistants, and in the case of what we're doing with sleep, even therapists, occupational speech, BCBAs, can provide certain types of healthcare to families, like the what I put in the chat about, for example, the cognitive behavioral therapy for insomnia. Similarly, for mental health, there are some great licensed clinical social workers out there who can make a real difference for people, especially if they don't have the means to go to a major medical center and see a psychiatrist, for example.
Thank you for giving or spelling that out for us. I think that that's something that if you're not familiar with the experiences of people with IDD that you would not think about, and even people who are might not think about those things. Another thing that I want us to think about is racism. So anyone who is not white, you know, can anticipate or have experienced racism in healthcare as well as in other sectors or contexts. But I wanted to ask you all about how racism contributes to the health inequities that we see among people with IDD. So I had to do a study on this, like a little literature review, and I was not surprised. I was shocked, but not surprised of the magnitude of racial health inequities within people with IDD. So I guess anyone could talk about that. That would be great. Oh, Darcy.
Oh,
Okay.
sorry.
Yeah.
So the studies we do have, we certainly need more. And there's no question whatsoever that the disparities are compounded across the intersectional forms of identity. What we know from some studies, for example, there was a nationally representative study that found that people with IDD from Latino communities are less likely to have received primary and preventative health care services than other people others in the IDD community. And another example is that another study found that Black people with IDD are less likely to receive dental care and other preventive health services than white people with IDD. So the evidence is there. We need more, and it's absolutely a call to action to both the healthcare system and to students looking into better ways to collect data on disparities, not racial and ethnic disparities, but also disparities disaggregated by race and IDD status.
So I want to thank Darcy for that. And I think it's, even when care is provided, I think that there's ample evidence beyond the anecdotal that the quality of care, there's disparities in quality of care, particularly in the areas of pain management. You know, clinicians are concerned about over-medication, and rightly so. And I think they tend to err on the side when they have communication struggles with people against over-medicating. But I do think that results in people having their pain not adequately managed. And I think that happens. I think we see that in people with intellectual and developmental disabilities not getting adequate pain management. And that's a concern for me personally. I feel like that's something we owe people with IDD, adequate pain management. And it's an area of disparity that I'd like to see addressed. I don't have an answer for that, but I think it is something to be concerned about.
Well, speaking of answers for things, and thank you, Beth, for starting off the conversation like that. Do you all have any suggestions for addressing racism in healthcare that people with IDD experience? And I will note that we know that racism is not just bias, but it's also structural as well. So some of the social determinants, inequities that you all were talking about, when they are along the lines of race and IDD or disability status, I would imagine that that's a demonstration of structural racism that impacts people with IDD.
Well, I think one thing, just like we've been talking throughout about the importance of the self-advocate voice, I have several colleagues who are Black, and they just have a very insightful view. Fortunately, several of them are very interested and engaged in IDD, and just hearing their perspectives. And then, of course, if you are able to have a Black or brown or whatever the minority is you're talking about, self-advocate, I think that's even stronger, because just like our self-advocates with IDD who are white know about the challenges of having IDD, our self-advocates who are also from minority populations. I think we really just need to encourage them to participate in this work and share their voices, because that's really what it boils down to, is the lived experience. When you hear people tell their stories of what they've been through, it's impactful to all of us in a way that just reading about it is not. It's so important when I hear those stories. So that's what I would advocate for. We had a program that Corey funded us. It's Patient-Centered Outcomes Research Institute, where we brought people together to learn about IDD and form research teams. So it was not just researchers and clinicians, it was parents and it was self-advocates. And we were very happy to have a very diverse group of stakeholders on that grant, because it was really important that we not only include people with IDD, but we include people with IDD who are coming from minority backgrounds, and similarly for the clinicians, researchers, and parents.
So I want to just echo what Beth said. When people tell you it's a problem, you should believe them. I think that's the starting point. And people are saying this is a problem, and I believe them. This is absolutely a structural problem. I think we can continue to collect data, but I think, and we should, but I think getting everyone on the side of becoming allies for change and working together, I think our struggle is coming up with the right actions to take. And I will tell you personally, I do not know what the right actions are, but I stand ready to act. And I think actions, they're probably, again, it's a multi-pronged approach from the micro to the macro. This is not a simple problem. It's not a one size, one action. And it's not a do it once. It's a do it over and over and over and over until things change. And I think that's where we are. And working together until things change, and then keeping it from changing and slipping back.
Thank you. Oh, go ahead, Darcy.
Yeah, I guess I would first say I'm coming to this subject from a place of humility. And I think something that would be good to emphasize is that it's not a zero-sum game. A lot of things that, if implemented to address racial health disparities, would also benefit people with IDD and vice versa. And another point is that we have acknowledged that these are systemic issues. Systemic issues require systemic solutions. And some of the most important work that we can do right now is strengthening and protecting access to Medicaid, improving Medicaid services, and things that impact the most vulnerable people in our communities.
Thank you. That's like health equity 101. You address the needs of those with the most needs, and that impacts everyone else. Yeah, thank you. I'm gonna combine 3 questions into one. So let's see how this goes. This is 2 questions from our audience, and then my next question. So someone asked, what is the racial representation among people with IDD? But it also made me think of a previous question that someone asked, is about like disclosing whether or not you have IDD, or one of your family members or someone that you are providing care for has IDD. So this is like an identity, as well as how do you disclose this, or should you, and in what context, if there are tips or best practices for that would be great. My question was going to be about gender, thinking about how the NIH and other funders do not fund research on women's bodies to the degree that they do for men. Like all of the studies are done among men for what they understand as like research rigor, but that's a whole other discussion. But I was going to ask about health and healthcare among people with IDD who are not men. So that was, I don't know if I did a great job at combining the questions, but those are those three questions about identities, representation, along race, gender, and identifying as someone with IDD.
Just say, in terms of prevalence for IDD, around the world, the prevalence rates are the same. It doesn't seem to change country to country, culture to culture, race. It's part of the human condition. What changes in prevalence rates is really what you include under the umbrella of IDD. Because from country to country, people will put more or less under their umbrella of what counts when they do their from a policy perspective, what they want to count as IDD. But prevalence rates for individual conditions are pretty consistent around the world.
Yeah, I just wanted to chat about I see something in the chat about guardianship. I don't know if this is addressing that specifically, but I wanted to say one of the barriers, I think, is that people with IDD either can't speak for themselves because they either have limited language or maybe they go off on tangents. I mean, we all do, right? We all have a little bit of that in us, but maybe people who are on the spectrum may have difficulty forming their thoughts in a more focused way, and the provider only has so much time. But then what struck me about the guardianship in the chat, and I don't know if the person who put this in the chat was thinking specifically of this, but the idea that oftentimes we speak as clinicians or providers to the parent or to the caregiver, and we don't let the person with IDD communicate because frankly, maybe it's going to take too long, right? Or there's some other reason, and that can be extremely frustrating for the person with IDD, and they're not necessarily able to even tell you what they need and what's hurting them or whatever. So I think that is still another area. Guardianship is important. Having medical advocacy is important. Power of attorney, of course. But also, even if you have that, one of the things I've learned in this arena is the importance of making sure that we still foster the voice of the person with IDD. We still figure out every way we can to encourage them to communicate directly with us. Even if there is a guardianship issue or a healthcare power of attorney involved.
Thank you. I'm just getting a question about how this conversation can reach other populations outside of the US. So Maggie, you mentioned that to a degree, but I just wanted to see if anyone had any comments about this person who asked the question is connected with Tulane, but is in Kenya, and is wondering about how some of the things that we're discussing, how they work outside of the US.
Well, the World Health Organization's manual, the ICD, has a international classification of diseases, has a lot of good resources and information in it, and provides guidelines for diagnostic information. But It also is the benchmark for countries in their own data gathering. So it's diagnostic information for clinicians, but it provides the benchmarks for countries for their statistical gatherings. So that may be of some use depending on where you're thinking of starting from in the dialogue outside the US. It's called the ICD, the International Classification of Diseases.
I'm gonna ask one last question. I don't know if we have time for everyone to respond, but I would, since our collaborative is supposed to be cross-sector, and it is not supposed to be, it is. But I was wondering if anyone could give an example of like a cross-sector collaboration. So maybe provide health providers with policymakers, or community organizations with academics, but a cross-sector collaboration on meeting the needs of people with IDD.
I'll start. I love that cross sector. It kind of builds on what I said earlier about creating these research teams that include people with IDD and clinicians and researchers. And the thing that comes to mind, it's not specifically IDD, but it's disabilities. And I think a similar thing could be done for IDD. I love to go to Capitol Hill and advocate. I advocate for sleep, of course, since that's my field. And when we go, it's never the lobbyist. It's always a researcher, a clinician like me. And it's also a patient with a condition. So for example, narcolepsy or some other sleep apnea, some other condition. And to me, that is super impactful when you're talking to policymakers, because they get to hear the lived experience and the stories of the people. So that would be what I would advocate for, no pun intended, when I advocate, right? The idea of bringing a team together, and you can actually train people, and they love it, train them in how can they be effective advocates. So you would have a person with IDD, you would have a clinician, you would have a researcher, maybe, depending on what the topic is, you'd have a family member. And I know Janet Schaus is on the call. I'm so happy to see her from Vanderbilt. She and I have advocated to our Tennessee legislature together for healthcare and other issues related to people with disabilities, including IDD. And it's just super impactful when you get those cross teams together, cross cultural, cross the idea of clinicians, researchers, and parents, and people with IDD together.
Yeah. Okay. Well, I think that's a great example, because it is an example of advocacy that, we have to work together and push for change. So really appreciate that, and really appreciate all three of you all for your insights, for being here today. I hope that it was helpful to the audience, both here live and people who will go back and listen to this webinar. So thank you all so much. Great. Okay, so with that, we are going to close the webinar. But before we do that, we'd like to learn from you about how practical and applicable to your work the conversations that we had today were. So we'd like to invite you to fill out a short survey that you should be able to access through a link in the chat, or by scanning the QR code that you are seeing on your screen. So you can go ahead and do that. It's going to ask you, how well did this apply to what you are working on? We might ask, what you want to see coming from this. So with that, we are concluding our session today and inviting you to join us on August 20th for our next webinar on education, access, and equity. We're also reminding you that we have a workshop series starting up on September 25th. If you have been a participant in our workshops, you know that those are always great. And also reminding you that we have a podcast, a couple of podcast episodes coming up on this very topic. I hosted the podcast. It was excellent, and I'm sure will be a great listen for you, and hopefully an activating listen. You can also see the link in the chat that was put in there earlier, but maybe we can put it in there again for an IDD toolkit that Beth mentioned. It provides information for primary care of adults with intellectual and developmental disabilities. You can follow us on social media and help us spread the word by sharing our content that most interests you and your work. See you soon, and thank you so much for being here.